Good afternoon here in America, and good evening to those of you watching in Kurdistan. It's a great pleasure to have you with us. I'm Bayan Sami Rahman from the Kurdistan Regional Government representation in the United States. And with me today are Dr. Christine Butts and Dr. Jagger Jassim. They're both based in America, and they are giving us their very precious time today to be with us to help us answer questions about COVID-19, the new coronavirus. Of course, we've all been inundated with information. I think we have too much information to the point where we can't tell anymore what's relevant, what's important, and what is not that important, or what is even misinformation. So this is why we wanted to invite these two wonderful doctors to be with us today and to answer some of your questions. So first, let me introduce Dr. Jagger Jassim. Please tell us, Dr. Jassim, a little bit about yourself, and then tell us about how you think things have gone in Kurdistan and, if you like, in the United States. And of course, you're an epidemiologist. Excuse me for mispronouncing that. I always mispronounce it.
I do that too. Don't worry about it.
So you have a very good knowledge about epidemiology, and so please introduce yourself to our audience and then tell us a little bit about how you see the picture, how Kurdistan has handled this, how the United States has handled it, and then we will go on to Dr. Christine Butts.
Okay, great. Thanks for having me, Bayan Khan, and thanks for everyone joining us today. My name is Jagger Jassim. That's the English version of my name, or the American version of it. The Kurdish one is Jagar A. So it's a very Kurdish name. I'm actually from Duhok, which is a city, for those of you who don't know, it's a city in the southern part of Kurdistan, which is the KRG region, or the Kurdish Regional Government region. I came to the US as a Fulbright scholar in 2010 and did my first degree in epidemiology from the University of Nebraska Medical Center, and then did my boards in internal medicine from the University of Colorado Hospital, and just actually finished my third degree in blood diseases and blood cancers from Johns Hopkins, and I'm currently a medical doctor at Johns Hopkins. My connection with Kurdistan is basically everything. My entire family is there, and I have just been there like 3 months ago before the epidemic happened. And I was planning to go back for Nowruz, but unfortunately, the lockdown happened and the quarantine and all of that, so I couldn't make it happen. But in general, I have been following the news as much as I can, obviously, about what's going on in Kurdistan. And I can tell a little bit about the situation in Kurdistan. Perhaps Dr. Butts can focus more on the US and the situation there. I believe that Kurdistan has done a good job so far. The KRG has done a good job. We have only a few hundred cases, which is, compared to the neighboring countries, is a really good thing, compared to Turkey and Iran and perhaps some of the other Middle Eastern countries. And we only had a few deaths. I think less than 10 people died in Kurdistan. And officially yesterday in Duhok, they announced that it's free of cases, which basically means they don't have any cases quarantined yet. And we didn't have any deaths from corona in Duhok so far, which is, I think, a part of it is due to the strict measures taken by the KRG and the lockdown that happened and the prompt actions that followed the diagnosis of the first case in Sulaymaniyah. I think they have been doing a really good job in that sense. However, I'm always cautious when it comes to analyzing data from even the US and, of course, and in the third world countries, what's called, although I don't totally agree with that term. But anyways, in Kurdistan, I don't think we have really good testing done. And that, I think, is one of the weaknesses that I can talk about. I cannot stress more on the importance of doing testing in the setting of coronavirus, because, unlike the other types of epidemics that we had, about 50% of cases might be actually asymptomatic, which means they have no symptoms, yet they can still transmit the disease to other people. So we actually, what we diagnose in general is just the tip of the iceberg, So it's really hard to tell if you're actually free from the disease without adequate testing. I think in Kurdistan, we have only done about 1,000 per million, which is way behind countries like, UAE, for example, which has done about 80,000 per million. The US is around, I think 12,000 now, and Germany is about 20,000. And there have been a lot of studies that support the idea of doing testing, because basically those 50% of patients who do not have symptoms are usually younger ages who can still transmit the disease to the vulnerable population, including the elderly population, and also people with comorbidities, which means other medical diseases. So I think that's one area that we can work on and kind of increase the number of testing before we announce that you are totally, corona-free.
Thank you for that. I think that really helps us understand, as I said, what's important, what is the correct information, what isn't. So thank you for emphasizing that testing is really the stage that we need to be at. And here at the KRG representation, we are trying to find help for Kurdistan, whether it's from NGOs, from USAID, the US government agency, or from other organizations. But of course, it's very hard because every country is looking for testing kits, ventilators, and so on. But nevertheless, we're still trying. So thank you for putting that in context for us. I just want to repeat the numbers, and I hope I got them right. You said that in Kurdistan, we are doing 1,000 tests per million of population, whereas in the US, it's 12,000 per million.
Yes, and of course, in the US, it's still way behind other countries like Germany and South Korea and UAE in the Middle East. I think UAE Emirates has the highest, about 70,000, I think today, as of today, 70,000 tests per million.
I see, right. Well, thank you for that. So now I will turn to Dr. Christine Butts, and please just tell us a little bit about yourself, your connection to Kurdistan, and then give us your thoughts about coronavirus, the new coronavirus.
Thank you so much. It's a real honor to be here with you today, with everyone that's watching. Kurdistan holds a very special place in my heart. My name is Christine Butts. I am an associate professor of emergency medicine here in New Orleans, Louisiana, in the United States. I have been working in this capacity since 2007. I did my school, I'm from the United States originally. I did my schooling in California and then came to New Orleans to do my training in emergency medicine. Emergency medicine is not a specialty that's established everywhere in the world, but basically an emergency medicine doctor is a physician who works in the emergency room and sees all the cases that arrive there, whether it's trauma cases or medical cases, or in the case of the last month here in New Orleans, cases of coronavirus. So I think to answer the question of how, a little bit about coronavirus, and I really appreciate Dr. Jasem's overview of how things have been in Kurdistan. Oh, let me back up and just say my connection to Kurdistan. So I first came to Kurdistan in 2013 as part of a capacity building team led by Dr. Ghazi Zabari. And I have been back to Kurdistan every year since that time, with the exception of this year, sadly, and consider Kurdistan to be kind of a second home to me at this point. I made a lot of friends and connections there. So just to kind of spin off what Dr. Jasem was saying, the United States coronavirus, because the United States is made up of course, 50 different states, which are all somewhat individualized. The response to coronavirus has been very different in all of these states. So some states have been hit very hard and have a lot of cases, like New York, or Louisiana has a large number as well. And these states have taken measures very similar to what you've done in Kurdistan as far as locking down events. Restaurants are closed, there's no public celebrations, those types of things. And that's really helped a lot as far as preventing the spread. But I would 100% agree with what Dr. Jasem said about the testing. Our testing is still not adequate here. We have a lot of people who are probably walking around and don't know that they're infected. and possibly, feel fine and can spread to other people who are much more vulnerable than they are.
Right. Well, thank you very much. And I also want to thank you for going to Kurdistan over the years to help our people and our medical professionals. So thank you for that. So I have some questions before we start to get questions from our audience. I hope they're all finding ways of sending in their questions. I think you can do it through YouTube and Facebook Live and Twitter if you're watching on Twitter. Now, we in America, those of us who are in America, and we also have some friends watching from Canada, and of course from Kurdistan. Lots of us want to know, when can we go back to work? When will schools open? When can we go back to the gym? All of that. Whether you're in Kurdistan, Canada, or the United States, the question is the same, frankly. We're all under lockdown in one way or another. We're all cooped up. Children are distance learning, and that's proving a huge challenge for some of us parents, me included. So the question is, how do we feel confident enough to be able to reach a point when we can go back to work or school? Open to either of you or both of you.
Yeah, it's actually a really hard question to answer. I believe that we'll have a lot of hard questions and answers today because we do not know much about the virus yet, unfortunately. But we, as physicians, scientists, epidemiologists, can always, make our own expectations, predictions, projections as what's going to happen. But at the end of the day, deciding when to go back to normalcy and when to do economic, open ups, and when people can go back to work freely, is not always a purely scientific or medical decision to be made. Sometimes we have other factors that weigh into it, including economic factors, political factors, maybe even geological and geographical factors, more precisely. And even if we think about it from a purely scientific or epidemiologic standpoint, we are still facing a lot of uncertainties and a lot of unknown variables. It will depend on whether we can actually develop a vaccine in the near future, and whether that vaccine can be implemented effectively, timely, and globally. Whether we can actually increase our testing capacity, whether we can increase the capacity of the healthcare system to accommodate more cases. And I think more important, the immune that people develop towards the virus is a long-term immune response or a short-term one, meaning, is it a one-time thing? I get it, I recover, and it's done, or whether it's going to come back again. So interestingly enough, there was a new study actually just published about a week ago by Harvard School of Public Health, and predicting basically that we will need some sort of what's called intermittent social distancing up till 2022. Obviously, granted that we do not have a vaccine by then. If that tells me anything, it tells me one important fact, which is we are probably going to deal with the virus in the foreseeable future, at least. Of course, those measures, the lockdown measures, may not be as strict as they are now, but, because basically we have other factors into them, but I think we have to be mentally prepared, at least, that it's going to take a while to get rid of this virus.
Right. So,
yeah, I'm sorry to interrupt. I would just say I 100% agree with that. I'm not an epidemiologist, but I think that, one thing that you really can't work into these models of when to reopen things is people's behavior. And I think certainly in certain areas like New Orleans, where we've had such a huge amount of cases and nearly everyone in the city has been affected, it's maybe harder to say, like, everyone go back out and resume your normal life. Because a lot of people are afraid, and they're afraid of getting infected, and they're afraid of, their neighbors, and afraid of going to the grocery store and those types of things. So it's difficult to say when life can go back to normal with that knowledge.
right. Well, thank you. I think this is one of the frustrations, but then it's better safe than sorry, I guess. If you see me looking away from the camera, it's because I'm receiving questions, so I have to look at them on my laptop. So there's a question here for you, Dr. Jasem, from Kawar Farouk. Do you think it's slightly premature to end the stay-at-home order in Duhok province? There could still be people that haven't been tested.
Absolutely. I think the only safe way to do it, means to open up life and kind of go back to normal life, is by doing more tests to know how many cases we already have. With the number of tests we are doing in Duhok, I don't think it's safe to open the streets and then public life. And again, I think it's still premature to do that.
Okay. Well, I have to say, I don't know what measures they've put in place in Duhok, whether things have opened up, but people are still being encouraged to have social distancing and wear masks. I'm not aware of what additional provisions have been put in place.
Yeah, I think based on what my understanding is that it's called partial opening the public life kind of thing. So basically people can still go out, but taking their own precautions. But basically there is no strict lockdown that like it was just a week ago. And I think those changes happened as if yesterday, because we technically don't have any cases quarantined yet, in the hospitals or the quarantines, but that by no means means that we have no other cases, kind of walking around in the community.
Right, thank you. So I'm going to read out the questions in the order that we received them. So from Nasreen Sinjari, there are reports of a second wave outbreak of the virus in China. In some cities, there is a requirement to wear eye protection to avoid contamination in this way. Since they are several months ahead of us, how do you think this will reflect in other countries?
And that question is for me or for Dr. Butts?
It's up to you, whoever wants to answer. Maybe Dr. Butts, I don't know.
Well, again, I'm not an epidemiologist, but I think we certainly looked at Italy early on and their experiences, and I think we experienced a lot of the same things, several weeks delayed from them. So it certainly would be one of the most important things, I think, of this epidemic is that preparation is extremely important and planning is extremely important. So if we're able to look at another country who has opened their lifestyle and has returned somewhat to normalcy and see what effects they've had, I think that that's something that we should be very prepared for here in the United States or in Kurdistan when they're loosening restrictions, to at least be prepared for that as a possibility.
And what about, she also mentioned that people are being required to wear eye protection.
I think one of the other things that's really challenging about this disease, and Dr. Jasem mentioned this a little bit, is that we don't know a lot about coronavirus yet and exactly how it's transmitted from person to person. There is certainly a thought, for example, when I'm in the hospital, I wear eye protection when I'm in contact with patients, because that is a theoretical means of either it directly coming into contact with my eye, say someone sneezes or coughs or something like that, or as human beings do, we tend to touch our faces. If you notice when you go to the grocery store, for some reason that's when I start to have an itch on my face and I just have to scratch it. So I think it's human nature that we rub our eye or touch our eye and we don't even notice it. So it's definitely a potential vector of transmit.
Thank you. I'll go on to the next question from Daria Monastriskaya. I'm sorry if I mispronounced that. There is such a huge difference in death rates in different countries. What is the reason for that? And is it true that the BCG vaccine protects people somehow from COVID-19? Dr. Jassim, do you want to try that one?
Of course, yeah. I think the first part of the question, which is why we have variations in the death rates among different countries, I think a part of it is just how many cases they have, and that can be attributed to different factors. But one of them is how many cases they have to begin with. The second thing is how well is the kind of intensive care unit functioning and the healthcare system in dealing with those cases, and also the number of the elderly population in different countries. For example, if you think about Italy, the median age, which is not the mean age, which means, the median means 50% of the population of Italy is actually above the age of 45. And that's compared if you compare that to Iraq, the median age is 20, which means 50% of the Iraqi population has, is older than 20 years old, and 50% kind of younger than 20 years. And in the US, it's about 40. So obviously countries that have a higher percentage of the elderly population will have more deaths to begin with. And another thing that cannot be overlooked is basically how different countries have different reporting systems. As we said, always, we can always repeat this, COVID-19 is more of a clinical, it's a lab diagnosis. We have to confirm our clinical suspicion with lab testing. With Ebola, for example, if you compare that to Ebola, we can clinically diagnose Ebola cases in the setting of epidemics or outbreaks. You have a young or elderly person without any history of bleeding, comes now with bleeding gums and nose and has fevers. We think that this is Ebola and be proven otherwise. But with Corona, it can mimic anything or nothing. So if those countries don't test people who die, it's impossible to know the actual numbers of deaths. So that's the first part of the question. The second part about the BCG, there have been speculations about this as well. Just to define BCG, BCG is a vaccine that we give, or it's given in a lot of countries in the world during the first week of life to the babies or to the newborns to protect them against future TB or tuberculosis infection. And obviously in third world countries or developing countries, it's a common practice to do. It's a routine test or a vaccine to be given, but not in the US, in the UK, and in other developed countries, because first of all, there have been questions about the efficacy of the vaccine to begin with, and also because those developed countries don't have a lot of TB cases. So they thought that giving this vaccine in the face of low incidence of disease is not a wise policy to be made. However, there have been new studies, especially a study done at the University of New York City University, I think, that showed variations in the number of severe cases in those countries that use the vaccine, the BCG vaccine, routinely, and those who do not use it routinely. So the idea is that perhaps this vaccine is giving some sort of protection to people. Whether this is true or not, it has to be tested. And currently there is a big study actually in Australia and Germany, UK, and Netherlands, about 4,000 participants recruited in that study to see how valid is that hypothesis that actually BCG can be protective against coronavirus. The reason why they think it's probably protective or can be tested at least is because, with each vaccine, there's something called specificity. Like measles vaccine only works on measles disease, and cholera is only for cholera, and hepatitis B is only for hepatitis B. But BCG actually is a kind of more generic type of vaccine that can work on different, viruses and bacteria. Because it works on a certain type of immunity called innate immunity, which is not very specific. So that's the reason why they think it might be effective, but yet it has to be tested and verified.
Great, thank you. So those of us who had BCG feel very lucky right now.
if that hypothesis is valid, as we said.
Yes, yes. So we have from Jyotyar Taha. My question is for both doctors. If and when a vaccine becomes available, when do you think third world countries with limited capacity would be able to receive such a vaccine? If I may, I'd actually like Dr. Butts, if you could answer this and maybe also give us your insights, being a doctor in the United States and then going to Kurdistan on a few occasions now, and maybe you're able to see the contrast. And what are your thoughts? How quickly could a vaccine be received in these countries with limited healthcare facilities? And Kurdistan does have limited healthcare facilities, but by no means is it in the worst category around the world.
I think that's a difficult question to answer. My hope would be that because this is a worldwide pandemic and we're able to see the effects on so many places in the world and how people are suffering, that there would not be a delay in getting a vaccine to places that maybe are have less resources, that perhaps through I don't know, some kind of action to limit the political aspects of that could happen. I think in my experience in Kurdistan is that the Kurdistan regional government seems to take care of its people very well, be very invested in the health of its people. And I think that as with anything, I mean, vaccination relies on the trust of the community in order to kind of buy into that and to accept the vaccine, and that might be a somewhat of an issue. But my hope is that certainly there won't be any roadblocks due to some kind of political situation or something like that.
Right. I hope so too. Dr. Jasem, I don't know if you want to jump in. If not, we can go to the next question.
I totally agree with Dr. Butts. It's really hard to predict it without actually having the vaccine. And the current thought process is that it's going to be available globally because, as we said, you know, we are in the stage of globalization, and what affects Kurdistan is going to eventually affect everywhere in the world and so forth. So the idea is to timely, effectively, and globally distribute the vaccine.
Right. Okay, so we have a question from Cheyenne Omar. Once a vaccine is here, how long do you expect it will take to mass produce, make it available to the general American public and to the public in Kurdistan? Please give us your predictions.
Yeah, so I think that goes in lines with the previous question. But in general, we think that the vaccine will be available in ever, of course, because we don't have vaccines for a lot of diseases, right? So it's not that we will have the vaccine available 100%, but if it is going to be there, it's going to probably take about 12 to 18 months, a year and a half. The reason why is not the technical problem. It's not technically difficult to make a vaccine. After we kind of sequence the genome of the virus and you know, identify it and so forth. But the main problem is, or the main issue here is to test that vaccine to make sure that it's first of all effective, and secondly, it is actually safe to be administered. You know, the last thing we want to do is to distribute billions of those vaccines and doses to people while it can actually harm them more than benefiting them. And there have been, you know, examples of those. In 1967, they gave a vaccine against one of the influenza viruses, and it caused a disease called Guillain-Barré syndrome, which is some sort of paralysis that happened. I think in 1980s, there was another phenomenon called disease enhancement with one of the vaccines in which the vaccine itself caused the disease to be more severe and more problematic. And fortunately, this is not the case with the majority of vaccines. I'm not an anti-vaccine person. I'm all for the vaccine, obviously. But we have to take our time to test it before we actually distribute it. But after the production of the vaccine, whether it's going to take a month or 2 months for mass distribution, I don't know that answer. I don't think it can be answered at the moment.
And I think it's really important to not put. Of course, the vaccination is important, and that's going to be really key to people resuming somewhat of a normal lifestyle in the world.
Christy?
Hello? I think I lost you. Sorry. Yeah. I think I lost my video. Just give me 1 second.
We can see you and hear you. Okay.
No, I was just saying, I think it's important that it's probably going to take quite a while for a vaccine to be widely available. And so to put a lot of stock on a vaccine being the thing that really saves us, I guess, is somewhat of a fallacy, because I think it's probably going to be at least a year, if not longer.
Right. Well, we have another question kind of about a vaccine as well. This is from Shivan Zebari. Since COVID-19 virus has been around for several years and it had been identified before, how come there's no vaccine for it? And then a follow-up, same person. If there is a variation of what was known to scientists before, in other words, this is like a flu that comes around each year, but it's a variation of that, is there a risk of the virus coming back down the road, even if we have a vaccine? Could it mutate and come back again?
So I'm a little unclear on the first part of the question. Is he saying that this virus has been around for several years? Is that the question?
Yes, COVID-19 has been around for several years and it was identified before. How come there's no vaccine?
So a coronavirus is a type of virus, and there are other coronaviruses known to scientists. However, this specific strain is a novel virus or a new virus. So it has not been known for several years, which is why we're struggling so much with it and why there's no vaccine available.
Okay, and then the second question, which somebody else asked as well, could the virus mutate? So even if we find a vaccine, could it mutate a few years down the line and then we're back to where we are today?
Yeah, it can definitely happen, and it has already happened perhaps. And in a country like Iceland, they have reported about 50 different mutations in the COVID the novel coronavirus. And in the UK, they have been mentioning numbers in the range of about more than 100 mutations have already happened. Fortunately, none of those mutations have dominated the picture yet, because perhaps they have not added to the function of the virus. The virus is already very specific for humans, and obviously only the mutations that kind of add some sort of advantage to the organism can dominate eventually. But again, we didn't have enough time to study all those different mutations that already happened. Are those going to continue to happen in the future? Very likely so, because that's the norm. It happens in every kind of life system. We as human beings have thousands of those mutations every day in different systems in our body. Whether that's going to be a problem for the vaccine, it definitely will be a problem if it's a frequent kind of difference that happens, or mutation that happens. And the vaccine might be ineffective sometimes. It might be effective for a short period of time, or it might actually be effective in alleviating the severity of the disease without actually preventing it. And that can be applied to even the flu, because we all get vaccinated against the flu every year. But, the reason why we get it every year is because it comes back with a new mutation. It's unlike the measles vaccine, where you get it once and that's it. And also, the idea behind it is to kind of decrease the severity of symptoms and not, necessarily prevent it or nip it in the bud, as I can say.
Right. Thank you. So we have a question from Paul Davis from the United States. Can Dr. Butts address the difference among different groups that are more or less likely to be affected by the virus? And how soon do you expect that we can get back to normal?
So I think the first part of the question about different groups that have been affected, I'll speak to the United States. I'm sure that this is probably similar in other countries as well. We have a high proportion of people being affected in some communities. For example, African Americans here in New Orleans, about 70% of our cases are African American, which is overrepresented for the number of African Americans in the area. Why exactly that happens, it's probably a complex question in regards to some things that are related to underlying health conditions, and also due to socioeconomic factors as well. Health disparities, people that are able to seek care, able to get have access to physicians or hospitals. There's a very complicated question. I think one thing that this has really done is just kind of laid bare a lot of the underlying health disparities that are there in the United States, at least, and made them so much more obvious. I've heard from a couple other places, Detroit, for example, is seeing similar numbers. and probably in Baltimore as well. Dr. Jasem can speak to that as well. Again, as far as when things going back to normal, I think I'm not sure that that's when you think of normalcy as far as you know, going to a sporting event and sitting with 40,000 other people to watch a soccer match or a football game or what have you, or a concert. I'm not sure that that could happen anytime in the next near future. Again, just because Dr. Jasem talks a lot about testing, and I 100% agree with that. Vaccination will obviously be extremely important as far as creating more of a herd immunity where a large proportion of people hopefully will be immune. And if you have one person that may be affected, and that person is almost kind of walled off from the rest of society. But then also, if we're aware of, you know, who is affected. So if you know, for example, in my community, if we know that there is a pocket of the city where there is a high amount of infection, then that can be isolated from the rest of the group. But I think without those measures, it's really difficult to say, well, we're going to go back to normal, you know, next week or next month. I think that's really impossible.
So just to, this is my own question for you, Dr. Butts, because you're an emergency doctor. One of the things that we hear about all the time is that the virus doesn't affect young people in the same way that it affects the elderly or those with underlying conditions. Can you tell us what's been your experience? You're actually on the front line of this.
I think that by and large, that is true in the sense that the majority of the patients that I've seen that have been ill and extremely ill have been older patients. But when I say older, you know, a lot of them are 50, 60 years old, which is certainly older, but it's not old by any stretch of the imagination. And a lot of these people are very active people. They're not invalid. They're not, you know, in a nursing home somewhere. They're active people that have a life and have a job and a family. I have seen some patients that are younger. I have seen some of those patients get very ill. So I think for someone that's in their 20s or 30s that thinks, you know, I'm not going to be affected by this. If I get sick, I'm not going to get that sick. It's really erroneous. So I have seen some of those patients, but I would say by and large, most of the patients have been old, and most of them have had some comorbidities, meaning they've had underlying disease like heart disease, high blood pressure, diabetes, those types of things.
Thank you. Right, so we have a question from a lady called Bayan. Why have governments and agencies given different advice about wearing masks?
I think a part of it is because we still don't know about the virus. We still have a lot to know about it. And obviously those guidelines are going to change even in the near future, you know. That's one thing. I think that's the key thing. And one of the I think clear examples is using, you know, masks or covering your mouth and nose in the public. It was not a part of the CDC guidelines in the US, but then they enlisted those about a couple of weeks ago. And that was based on the fact that about 50% of people turned out to be asymptomatic based on new studies. So if you have, you know, if you have no symptoms and you go out and you don't use the mask and you sneeze somehow or you cough somehow, and then you can transmit the disease to a larger, you know, number of population. And the second thing is that, you know, a part of it also is the different governments have different, perhaps, assessments of the needs that their people have. You know, it's probably it's not very practical to use masks everywhere in a country like Iraq, for example, in Kurdistan, even in the US now. So they have, instead of saying using N95s whenever we go in the US, they're saying you can even use a normal mask, but we don't know if that's actually effective or not. And there are also questions about, you know, when you wear the mask, for example, you touch your face, and that can also be a port of entry for the virus. So the short answer to that question is a lot of those guidelines are changing and will change in the future as we know more about the virus.
Thank you. Sarkaft Omar asks a question about, do you think the COVID-19 virus is mutating, and will that pose a challenge for making a vaccine? I think we addressed that, but if either of you feel you want to add anything, please do.
I think we kind of mentioned that in details that it's actually mutating. We have probably hundreds of mutations now. None of them is really dominant yet, as far as we know. It's probably going to continue to mutate in the future, and if that's going to affect the vaccine production and the efforts, it will probably do. But we don't know yet because we do not know how significant those mutations are. But again, the idea behind the vaccine will not always be to prevent the disease, like you will not get it when you have the vaccine, but even if we can actually decrease the severity of symptoms, that will be a huge feat in that case.
Right. I have a question from Kawar Farouk. Dr. Butts, since you're on the front line, you're at the ER, people are answering, people in the US are protesting against, I guess, the clampdown and lockdown. Some are also dismissing many of the videos of nurses crying, saying that they're doing long shifts and they're not fully prepared for what's going on. What are you actually seeing in the hospital? Are medical professionals adequately equipped? Are you adequately protected? And what are your thoughts about the protests? If you feel it's getting too political, it's up to you whether you want to answer or not.
No, I think, so to answer the question about the protection, that is an area that has been a real struggle for us in the hospital. We don't have proper equipment. We have had to, I guess you would say, kind of make do with what we have. So for example, some equipment that's designed to be used one time, we're having to use over and over and over because we just don't have an adequate supply to use as it was intended. You know, for us in the hospital, this is a really scary time. I have friends who have been infected, who have gotten sick. I've seen nurses that I've known for years and years who've been my patients, and seeing them struggling with their breathing. It's a really scary and very, very real thing for us to know that when I go to work, I could get sick just from doing my job. As far as the protesters go, I think, you know, the thing about social media is that it really amplifies everyone's voice, which is great. But you have some people who have their opinions about things, and those are also amplified. And I think sometimes the more controversial and the more outrageous they are, the more they're amplified, because people look at it and say, oh, I can't believe this person is saying this. And so it gets really kind of made bigger than it is. I think for myself, I know the spirit in my community has been one of support. We've gotten a lot of outpouring of support from the community, just in saying, like, thank you for being there for us and thank you for your work and all those things. So to me, that outweighs what I might see on Facebook or on Twitter of a handful of people who I think perhaps maybe have not been personally affected, so they don't understand the real toll that this is taking on people.
Yes, well, you definitely have our appreciation, all of you, Dr. Jasem, all of your colleagues. You know, you're in the front line of this, so we're all definitely extremely grateful. Okay, so now we have a question from Dr. Ghazi Zebari, who both of you may know. He's a very well-known doctor himself. His question is, when should surgeons be permitted to perform elective surgeries?
Well, I can answer, at least from what perspective I have. I'm not a surgeon, so you know, I can't answer from that perspective. But I will say our testing at our hospital has gotten markedly better. A couple of weeks ago, when someone was tested, it would take about 5 or 6 days to get those results. At this point, we're getting results in under an hour. So yeah, so it's actually quite good. So just like Dr. Jasem was saying earlier, there's so many people that are asymptomatic. You know, that was a big concern as far as performing our elective surgery and saying, I'm going to operate on this person and potentially put my entire team at risk of being infected from this person who has no symptoms. At this point, we're able to test a lot faster and a lot more thoroughly. So if someone is planning on having an elective surgery, we can at least test them now and feel better about not running the risk of infecting an entire team of surgeons and nurses and in the operating room.
So again, it's back to testing. Once testing is more commonly available, more of these things can go ahead.
I think so, yeah.
I should have added that Dr. Zebari wrote also a message to the KRG. Congratulations to the KRG, to the Kurdistan medical community and Kurdistan security forces for being proactive with the implementation of the preventative measures. So thank you for that, Dr. Zebari. Okay, a few more questions. The seasonal flu doesn't survive the summer heat. I'm not sure that it doesn't survive, but I think it's less proactive from a layman's point of view. Does extreme temperature, hot or cold, kill the virus?
We have no data yet, actually, to support either claim, whether it's actually affecting it or not. But we have some countries like Singapore, like Australia, that still have the virus. So we are hopeful that, you know, during the summertime, the speed of spread or the severity of disease might go down. But we have no data to support that. And always, I say, in medicine and in science, we have to always support what we say with data and evidence. I think, and not only me, some other epidemiologists also think the same way, that perhaps the virus will have its peak from October till May. So those cases might decrease, but actually, so that's another thing about the single isolated kind of lockdown policy or social distancing. We might actually be doing a really good job in the first wave of the policy, or you know what's going on now in Kurdistan, in the US, and everywhere else in the world. And we might enjoy a period free of the virus during the summertime, but actually doing it only once and abruptly kind of ending those measures, those preventive measures during the summertime, might actually push the second wave and more cases to come during, you know, October, November time period, which already coincides with the highest activity of the virus. So that might actually overwhelm our healthcare system even more. So those have been some of the concerns, but whether it's going to happen or not, we still don't know.
Right, thank you. So a question for Dr. Christine Butts. Do you see any cases in the United States of people being infected more than once? So they recover from COVID-19 and then they're reinfected. Have you come across that?
I have not. And I know maybe Dr. Jasem can talk a little bit more about what he's seen in the epidemiologic literature. I have heard anecdotal cases of that just in other places that maybe are a few months ahead of us, like South Korea, China, and those areas. I have not personally had any cases where a patient was infected, recovered, and then was reinfected.
Okay.
Yeah, I agree with that. Actually, there have been some data from China, especially, that there are a lot of new cases, or usually asymptomatic, for kind of reinfection. They had the virus, they recovered, they tested negative, and then the disease came back. Also, I think one of the cases discovered on the Princess Diamond, cruise ship, was reinfected by testing. So basically, he was claimed to be, cured from the disease, and then they tested him again, and it came back positive. It's likely going to happen because we know it's probably the immunity that our bodies develop against the virus is not a long-term immunity, and that is the main reason as why it comes back. We can always test for it, something called serology testing. We can test antibodies, and if our bodies, because when we get infected, our bodies produce certain chemicals called antibodies. We can always measure those. However, what our testing will do is actually the numbers of those antibodies, the quantity of them, or the presence or absence of them, but they will not actually, estimate the efficacy of those antibodies or the quality of them. So you might actually have antibodies. Our bodies might produce those chemicals to fight the infection, but they are probably not very functional after some time. So that possibility is there.
Right. We have another question. The United States might stop funding the World Health Organization. I think there's a moratorium right now, but in the long term, if the United States stops funding the World Health Organization, how much would this affect developing countries that need medical supplies, especially places like Kurdistan, where there are many displaced communities and refugees?
I don't pretend to be an expert on the World Health Organization, but I think, I will just say, without getting into like the underlying, a lot of this is very political, as you know, and there's a lot of underlying reasons for this talk about defunding that are not maybe are very political in nature, but I think that would really affect the United States as a major donor or a major funder of the World Health Organization, and that would obviously affect the availability of that organization to do its job and to help countries that have less resources. I think that would be a huge mistake, personally, especially in this time of worldwide need, for us to defund an organization that does so much for people around the world.
Dr. Jasem, I don't know if you want to add anything.
Yeah, I totally agree with Dr. Bas. I think it's a whimsical decision and not based on really solid data, and it's a very political decision. The United States of America has always been the #1 funding agency or stakeholder in funding the World Health Organization, and that has tremendously helped developing countries and even developed countries in those efforts. And what's going on, and if that actually happened and we cut the funding of the WHO, that would be a huge mistake and a disaster, actually.
Right. So I will go to, we have a few more questions. Dr. Ari Said, how does the HBO, Hyperbaric Oxygen Chamber, play a role in treating COVID-19? There is a trial in New York. Any updates or ideas? I think if either of you are able to answer that question, perhaps you could explain what HBO is.
So HBO is hyperbaric oxygen therapy. It's basically a way of, if you think of, in our environment all the time, of course, there's oxygen in the air that we breathe at a certain percentage. Hyperbaric oxygen uses a higher amount of oxygen under pressure to help for a lot of different disease processes. It's been used for wound healing. If you think of divers, like people that go underwater and get the bends where they have an emergency that develops in their body with the amount of oxygen and nitrogen, that hyperbarics is used to help those patients. And there's an idea that because coronavirus causes a severe hypoxia, meaning decrease in the amount of oxygen in the blood, that perhaps hyperbaric oxygen could be used to help increase the amount of oxygen in these patients. And perhaps when our coronavirus patients, we see kind of a predictable course of disease in which patients may have some symptoms in the early days. They may have kind of like the flu, they feel achy, they have a fever. And then after a certain amount of time, usually about a week, they start developing some respiratory symptoms. They start to feel short of breath, coughing, those types of things. Their oxygen becomes low at that point. Some patients will get better from that point and do fine. Some patients will get dramatically worse, and those are the ones that typically wind up on a ventilator, who have their organs fail and things like that, the really bad cases we hear of. So there is some thought that hyperbaric oxygen may be able to help prevent that downward slide. I know at our facility, we actually have a hyperbaric oxygen chamber at my hospital. We are in the early phases of trying to do a study to see whether intervening in those patients early on can help keep them off of ventilators. That's extremely important. As everyone knows, ventilators have been really in the news as far as the shortage of ventilators. So the more patients we can keep off a ventilator, the better we are. I don't think that data is really there yet, and that's probably just a factor of, we've been dealing with this for a little over a month. So, that will come in time, and I hope that is a good treatment, because if we're able to intervene in these patients, that would be huge.
Great, thank you. Thanks for that. And right, just making sure I'm not missing any questions. We hear about serology testing. Can you explain how that works and do you recommend it? I have no idea what serology is.
Yeah, we kind of mentioned that. So serology means, so basically what we do now for diagnosing coronavirus is something called PCR, right? So we amplify the genetic material of the virus and see if the patient actually has the virus or not. What serology does, it looks at the aftermath of the interaction between our immune system and the virus. So the antibodies, basically. The virus is the antigen, it comes into our body. Testing it with the PCR is the antigen testing. And the serology is the antibody testing, which is our body's reaction towards the virus. There is one study or one test that has been FDA approved. But again, I think it can help us kind of figure out whether somebody was exposed to it before, because we have two types of antibodies that our bodies produce against viruses. One of them is called IgM, which is the immediate one. It happens during the acute phase of the infection. And then once the infection is gone and we recover from it, hopefully, our bodies develop something called IgG. So it's going to help us quantify how many cases we had and probably always had the disease and were never actually diagnosed and so forth. But that test is not going to be of much help in determining how immune we are and how strong our immune system is against the virus, because it just looks at the presence of those antibodies and probably their quantity sometimes, but not their quality or their function. So having those antibodies does not mean that they're actually there and able to fight against the virus in the future.
Right. Okay, and then a question from Mr. Farhadi. How long does coronavirus usually remain in the body of the person who shows 0 symptoms?
Good question. I don't think that we really know the answer to that question.
Yeah, I agree. You know, by definition, the patient has no symptoms. So it's really hard to tell when his body is going to get rid of the virus. But in general, for most people, it stays in the body for about 10 to 14 days. Obviously, some cases it stays longer, some cases shorter than that. It's just like, let's say any other respiratory virus. Some people get sick for 3 days, some people for 2 weeks, some people never recover from it. So we can think about it on those lines, but whether there are differences in the asymptomatic versus symptomatic people in terms of how long the virus stays in their body is a question that we don't know how to answer, and there's no answer to it, as of now at least.
Okay, and then another question from Jen Peterson. What would be a safe time period from a last recorded case to assume that COVID-19 is no longer present in a community?
I think it's a fallacy to think of this as being kind of a temporary problem, that we're going to get to the point where COVID is gone and then that's the last we have to deal with it. Just like Dr. Jasem was saying earlier, this may wind up being something that's seasonal, just like the flu, where every fall, we have an influx of flu patients, and then it gets less in the summer. To think that this is sort of a sprint where we're going to be dealing with this for only 6 weeks or 2 months, and then that's fine, we never have to hear about it again, I think is somewhat of a fallacy.
There's a question that I omitted to mention earlier. I think we've covered it, but let me just mention it. Ahmed Damirhan, some universities are considering to open their campuses in 2021. When do you think it's safe to open schools and universities? Maybe we've covered this, but feel free if you think we haven't.
Yeah, I think we have covered this before. It's really hard to predict that. It depends on a lot of factors, including whether this virus is going to come back again, if we can develop a vaccine against it in the future. But based on the most recent study in that regard is that we will need some sort of of intermittent distancing, not strict ones, up till 2022 perhaps. So that question is really hard to answer, because also we have, as we said, economic dimensions to it and political dimensions to it. So despite we as physicians, scientists saying it's not safe to open it right now, but economists might actually push for it, or politicians might say let's do it right now because it's for the sake of the entire country. So that's why the exact timing is impossible to be given at the moment.
Right. Sarkaf Domar, who asked a couple of questions earlier, he says, I'm a researcher in the virology field. Are there any collaborations or scientific communications between researchers in Kurdistan and the United States in terms of finding a solution or a vaccine for COVID-19? Do you know of any collaborations between the US and Kurdistan? If there isn't one, could we create one?
I don't think that there is any. I'm not aware of, actually. Let's put it that way. And hopefully we can create that in the future.
We should really try to do that. Now, let me think. I think, and the same person, Sarkaf Tomar, saying, are there any researchers in Kurdistan that could get funding for researching COVID-19? Are there any scholarships? Are you aware of anything like that?
I am not. Are you aware, Dr. Butts, of anything like that?
I know that, one thing I would say is that I have seen a lot of journals and so forth really wanting research. It doesn't help so much with the funding, but if there is research, or if anyone is even just epidemiological studies of what's happening in Kurdistan, that people are really hungry for articles or research on this topic. So if someone does have something they're seeing in Kurdistan or in their community, that would be something that might be an opportunity for them to publish that.
Great, that's a great idea. Thank you. So I think we're at the end of our hour. We've had 60 minutes online and we've answered a lot of questions. I say you have. I want to thank you both once again. You're both extremely busy people and you're at the front lines of this. So thank you for devoting your time to taking these questions. If there's any last point that either of you want to raise, please go ahead.
Thank you very much for having us, and hopefully we could give some information to people, and hopefully we have contributed a little bit to kind of increasing the awareness towards the current epidemic. I think one thing for Kurdistan is just to not kind of expedite the process of removing the lockdown and taking it step by step. And I've heard that they're applying for some celebrations in certain parts of the Hawk, kind of to announce a victory against the virus. I think it's too premature for that, and I still recommend that people decrease their social interactions and frequently wash their hands as much as they can.
Thank you. That's very important.
I would just say thank you so much for having me. As I mentioned before, Kurdistan has a very special place in my heart, and I'm honored to be included. I would just say that this has been a very difficult time for everyone, and I think kind of around the world, just seeing people, family members, friends get sick, the uncertainty of what's going to happen. No one really knowing, when, like we've mentioned so many times today, when is life going to go back to normal? When can I go back to my job? When can I see my elderly parents again? All of those types of things. I think it's a kind of a natural instinct to fear what we don't know. But that, I think the real key is for everyone to work together. And that would be my hope that, throughout the world, since we're all going through this at the same time, that we'd find a way to help each other and to collaborate and to recognize that we're all in this together. So, yeah.
Thank you. Well, thank you both again. You've been wonderful. You've definitely cleared up a lot of questions for me, and I hope that's the case for those who posed those questions and others who watched. Before we say goodbye, I do want to thank my team who made this possible. Alex Ebsari, who's been taking care of the technology side of things. Dilovan Barwari, who's been fielding questions that came via YouTube. Karwan Zebari, who's also been fielding questions. And this actually was Karwan's idea. So thank you all to my colleagues. Thank you, Dr. Butts and Dr. Jasem, for joining us. And thank you to those of you who've been watching us live. Keep washing your hands, stay well, and stay at home. Bye-bye.